Hey there, I'm Dr. Brandon Deason, and in this first episode of DDQX Learning, I'm going to show you how to correctly answer most questions on stable angina. Alright, let's start by taking a look at our first case. Go ahead and pause if you want to give it a full read through. I'm going to begin by removing our answer choices and spreading out this text a little bit more. Now, the first P of my 5P approach to answering questions is going to be to pause as we go through it and identify the key information. The first line, we're going to be looking for risk factors. These are going to include the patient's age, gender, as well as any past medical conditions that are mentioned. So in the event of this case, we have a 68-year-old man with a past medical history of hypertension and hyperlipidemia, both of which are cardiovascular risk factors. The next thing to keep an eye out for is the presentation. What brought the patient to you today? That'll typically be in the latter half of our opening sentence. And in this case, we are told this gentleman developed squeezing chest pain along with dyspnea while on a hike. The follow-up sentence also adds important information that the pain only lasted for 10 minutes and was relieved by rest. Our presentation so far is lining up with stable angina, but it is essential to check that pertinent history next. This gentleman has had 3 or 4 similar episodes before, but of less severity and duration, and that's going to be the typical story with stable angina. Remember, if it's a new onset chest pain, it's by definition not stable. So, as we move on to the initial findings, aka as he shows up to us right now in the ED, we're going to look at his physical exam, which shows no current abnormalities, his vital signs, which are within normal limits, his 12-lead ECG, which is showing no ST changes, and his cardiac markers, which are within normal limits. Lastly, we have the additional information, anything that's provided after the patient's initial presentation. In this case, we're told our gentleman has to undergo an exercise stress test before he can be discharged. So he undergoes it, his symptoms are reproduced, and lo and behold, we find 1 to 2 millimeter ST segment depressions in leads 2, 3, and AVF, which will finally lead us to that question, what does this indicate is going on in his heart, aka what would we find on angioplasty? Alright, now that we've summed up all that key information, I want you to move to the second P of my 5P approach. Paraphrase. This is going to be a key skill not only as you move through your test preparation questions, but as you move into clinical rotations and you need to quickly report back the key findings to your resident or attending physician. So, take a moment, take that paragraph of information, and condense it down to just the key facts as I have here on the left. Alright, now let's go ahead and use this key information to differentiate between stable angina and the other most likely conditions. Our stable angina presented with chest pain that came on with activity, resolved in under 15 minutes, and was relieved by rest. The ECG was normal. The cardiac biomarkers were normal. Let's see how unstable angina compares. The chest pain here is either new, comes on at rest, or lasts longer than 15 minutes. The ECG may be normal, but you might also get to see ST depressions or T-wave inversions as clues. Cardiac biomarkers will be normal. Next up, the case of NSTEMI. This is going to involve sudden and persistent chest pain. An ECG that's either normal, has ST depressions or T-wave inversions, and cardiac biomarkers will be elevated here. This is going to differ from STEMI, where we're going to have that sudden and persistent chest pain, but the classic ST elevations indicative of infarction, and of course the elevated cardiac biomarkers. Lastly, we have vasospastic angina, which is known to occur at rest, status post often substance use, and most importantly, you need to remember this is a diagnosis of exclusion. So we're always going to want to check our ECG and cardiac biomarkers and make sure it's none of these other conditions first. We are not going to get any big clues here. We're going to have normal ECGs and normal cardiac biomarkers. All right, it's time to move on to the third P of the 5P approach, and that is going to be, we're going to take all of that information, apply what we know, and predict what the correct answer should be before we move on to those answer choices. So, let's take a look at these 4 boxes I have over on my right and go through them one at a time and make the prediction of how it's going to impact our answer choice. So first up, how does the percentage of vessel occlusion affect our presentation? All right, so our patient has symptoms of chest pain. This is going to require at least 70% occlusion of a vessel. Second, how do our ECG findings impact this presentation? Well, in this case, we don't have a STEMI occurring, so we know that we're going to have less than 100% occlusion. Third, how do the affected ECG leads relate to the anatomy of the left ventricle that's affected? So, our ST depressions were found in leads 2, 3, and AVF. These are known as the inferior leads because they are associated with the inferior portion of the left ventricle. And fourth, we're going to match our ECG findings to the associated coronary vessel. So the vessel that feeds the inferior portion of the left ventricle is going to be the posterior descending artery, which in roughly 85% of folks is going to be a branch of the right main. Occasionally it comes off the left circumflex, occasionally both. And we're moving right along to the 4th P, which is going to be to compare and pick that match. So do not let the work of your prediction go to waste. Make sure that you take that prediction straight to those answer choices and see if they say the same thing. So I've put the prediction up on the screen. Which of those fits our parameters? That's right, answer choice C. The last of my 5 Ps is prepare for future cases. So whenever you finish looking at a question, make sure you don't just see why you got this one correct, but how can you be prepared for the next case you'll see, since you're never going to see that same one again. So here I've taken those risk factors and made them a little more generic. Same with the presentation, pertinent history, initial findings, and additional info. Now I want you to take it to the next level and write a new question and add it to the comments below. Thanks for watching, and I look forward to seeing you in future videos.